The Conversations on Health Equity Online video series is produced by the Health Policy Research Consortium, funded by the National Institute of Minority Health and Health Disparities. Located in Greenbelt, Maryland, under the leadership of our principal investigator, Kwesi Nfume, HPRC conducts policy research on issues related to health inequities throughout the country with a focus on the Mid-Atlantic region. HPRC uses a transdisciplinary research approach to close the gap between policy and science by assessing how current and proposed policies affect various populations. Major research efforts underway include the Health Policy Literacy Study, the Policy Portal, various research papers focusing on behavioral and social sciences, and a cardiovascular disease study focusing on disadvantage in the food, built, and social environment. For more information, visit our website or our social media channels.
Well, that leads perfectly to my next question. I'm thinking about the word prioritization. With all of these complex challenges involving human lives, saving human lives. How do you decide what are your biggest challenges? You can't do everything. You can do something about many things, but how do you prioritize the biggest health challenges to target from such a long list?
So I'll say two things about this. First, we have worked on development of what we call a framework of research. So in thinking about our topic, we're not so focused on, well, what is the pathway for cardiovascular physiology, for example, or how the cell works in once it's got injury with a heart attack, for example, or stroke. We are looking at a framework that focuses on the individual, their biology, what is the genetics that they bring, the physiology that they bring, how does that react to the environment and to your lifestyle. Also the behavior that individuals have, and the behavior spans from not just substances, but also nutrition, environment that you're in. Then the network, the social networks, the family, the interpersonal society around you, because that is not well understood, how it is that either helps or hinders one. And similarly, the community. So expanding from the individual to the family to the neighborhood to the community. And that's both on a social perspective, so the people around you, and then the environment, so the place you're in. It is now well established that independent of your age and gender and race, ethnicity, if you live in certain parts, you will live longer than if you live in other parts.
Place matters.
Place matters. And this is after adjusting, of course, for categories of income. We know that people with more income or more wealth live longer, and that's true in Washington and San Francisco and in London and places that have been studied. But amongst the poor, the most vulnerable, we sometimes see dramatic differences between places. And so what are the places doing well that are helping the most vulnerable actually live longer? That's another area of study. And then we're interested in systems, and that expands out of the normal scientific inquiry, I think, in some cases. So we're interested in, well, what's the economic system, transportation, schools, zoning, all that kind of things that affect health. But also healthcare system, which really should be of interest to NIH, and is, but I think it's a particularly underemphasized area for studying health disparities, and we would like to emphasize that. Now, having said that, we are interested in the leading causes of death and disability in the U.S. So that's heart disease, cancer, and stroke are the top three. And then you can go down the top 10 list, and all these are familiar things. You will see diabetes there, chronic kidney disease, chronic lung disease, Alzheimer's or other dementias are included. Accidents, violent related mortality is in the top 10, and acute infections are there as well. So pneumonia usually is in the top 10. To give other topics, though, specifically, cigarette smoking is the leading cause of preventable morbidity and mortality in the United States and maybe the world. It is 30% of all cancers. So as a moonshot to prevent cancer, if we got everybody to quit smoking, we'd have better results than we could from almost anything else. Diabetes, as I mentioned earlier, the consequences of severe obesity, leading to both metabolic abnormalities, musculoskeletal abnormalities, social stigma, isolation, and nutritional disorders. Violence, the consequence of both interpersonal violence, beginning early in life. Gun violence gets all the press, but relationship violence, both in terms of home, parental, and neighborhood. And then structural and individual racism is a particular area that we're interested in. So what does living in an environment where you have racism functioning or discrimination functioning in a systematic way, not just John, you're a racist, you're mistreating me, what does that do to me? Yes, that's a possibility, but I live in a place where there's a structure that creates discrimination. And now, as we understand more about the way physiology and biology works, what is that doing to your body at age 15 or 18 that then comes out at age 45 or 50 as a chronic disease? And I think that's an area of active research. And then I mentioned healthcare setting with access to healthcare and quality of health care. It's not just access, but then once you get access, the quality that you get. And then aging and disability. We're all getting older. The charge to society of caring for people as we exceed 80 years old is going to get disproportionately affected. And although right now underrepresented minorities or minority groups are a smaller proportion of people over 80, with the possible exception of Asians, it's going to change as this demographic profile of the United States changes. So.
I'm thinking about all of these efforts that you're describing, and I'm imagining that if you put all of this work, all of these findings into a book, you'd have thousands of books, filling libraries, which is probably the case. If you go to health science libraries across the country, a lot of the work there is driven by the NIMHD and by other NIH centers. I'm wondering, as you look at all of that tremendous body of health disparity research growing out of NIMHD efforts and other NIH institutes and centers who are focusing on health disparities, what are the biggest lessons, the biggest scientific achievements? What are the big the eureka moments where we've learned something different that moves the needle in the effort to close the gap for racial and ethnic minorities, or for some of the other groups that you mentioned, rural communities and others? What are we learning through all of this?
Well, I don't think I can do justice to the broad set of knowledge that has been advanced over the course of the years. I can reflect on my own work probably more profoundly, but I won't. I think NIMHD funded projects. We try to, every 3 or 4 months, look at what are the highlights, what are the things that we're finding that matter, and so I can share a couple of those. I already mentioned the issue of, what does race, ethnicity contribute to our understanding of biological differences or changes? So we observe, for example, that African American men have an incredibly high rate of prostate cancer that no one can explain. And it's not just a little bit higher, it's not statistically significantly higher, it's double, triple what other groups have. So you say, something obvious is going on that we don't understand. And I think trying to understand that is one of the big challenges. Of course, you could say, well, that's cancer's responsibility, maybe, but we are also taking that as a major part of our interest. Parts of the puzzle could be in nutrition, parts of the puzzle could be in early childhood exposures, we don't know. And most of the emphasis has been on what about the genetics? And there are a number of genes that have been identified that increase risk, that are more frequent in African Americans. There are also genes that have been found to increase the severity of prostate cancer, and that's another example.
So not just the susceptibility, but also the severity of the illness
Correct.
could be determined
Correct.
by genetic
Correct. This is not Mendelian genetics. This is not a you have it or you don't. It's really genes that modify the risk, and these genes not only modify the risk, but the genes themselves are modifiable, and that always express completely. And this is what we're calling this area of epigenetics, where over a period of time, your behavior, your environment, some things that happen to you may modify the genes. Another example that fits in that category is the risk of chronic kidney disease. There's a gene that is protective of sleeping sickness, transmitted by the tsetse fly in West Africa, that is called APOL1. And that gene increases your risk of chronic kidney disease. It's carried predominantly by African American populations in the U.S. Now, it's not the explanation, because you still get a much increased risk from hypertension and diabetes. But if you have all three, then your risk is considerably higher. Hasn't been studied yet in other populations that have African admixture, such as certain Latino groups. So they think there's an area of more research. In terms of access, we recently, one of our investigators published a paper showing that African American women who went to who have babies go to hospitals that have worse outcomes compared to their white counterparts. So maternal outcomes, both in terms of infant mortality and maternal mortality, which is consistently higher for blacks, may not be any. The explanation may in part be related to the kind of care they're getting, and not just other factors related to either behavior or biology that have been postulated.
It may be a healthcare delivery solution.
Delivery
at some level.
Correct.
To that challenge.
Correct. Healthcare delivery. Can you make this inequity either decrease it or make it even if you provide the same quality in these different settings? Linking some of these accomplishments to NIMHD exclusively is challenging. So some of it is on the discovery side. What are the mechanisms that we can discover that help explain why certain things happen? So we know, or we have a better chance of making a difference by intervening in the right place. And the intervention might be at the individual level, might be with medications, might be with adherence, might be with the system, it might be in a social intervention as much as others. For example, another one, this is part of your interest in policy research. There is a study that shows that if you give poor people in public housing, these are mostly women, single parent, mothers with dependent children, a voucher to move to subsidized housing, but it has to be outside of a low-income neighborhood. So you can use this voucher, but you have to go to these other neighborhoods. And that they actually subsequently are shown to have a decrease in weight, decreased risk of prediabetes, and their measures of diabetes or glucose control are better years later. Their children have differential results. So the children who move with their moms to these other neighborhoods, the girls tend to thrive and do well. Boys and girls, pre-adolescents, also do better to their counterparts who stayed in the low-income neighborhoods. But boys who are adolescents, so early teen, don't do well. In fact, they do worse than their counterparts. So there is differential
Some other dynamics are at play.
differential effects of policy changes that sound like, okay, this is an economist saying, well, this is what we do, and we'll make things better by moving people to a different structure, different system, different neighborhood, different place. But yet it could have an adverse effect on a segment of the population. Maybe what's going on is related to doesn't fit, discrimination, not quite the right environment for someone who's past a certain point in life.
So there are policy interventions that have promise, but we have to be careful about how we think about, I think, those interventions.
Absolutely. I mean,
Yeah.
the biggest policy intervention we've experienced in the last 6 years is the increased access to care. So the proportion of uninsured persons between 18 and 64 has dropped by 50% in the last 5 years, in the last 3 years predominantly. Much of it is expanded Medicaid, not exclusively. And what will that mean for their health care of these persons over a long time? And it'll take years to really determine that. But we do know that for many conditions, access to health care is a sensitive intervention that will improve things. We know it from Medicare data. We know it from other experiments or other studies that show this. So I think this is an area that is critically important to study. It's a policy intervention, so there's no control. It's basically, this happened, let's see what the results are. And a lot of times, that's what we end up having to do. It's not a laboratory experiment. But with large numbers and good data, we can come to reasonably good conclusions.